All right, I think we'll go ahead and get started. Um, Thank you everyone for joining us this afternoon or this during your lunch hour. Today's emerging conversations will be on the Nirsevimab shortage and the RSV maternal immunization. So before we jump right in, let me just give a couple of small rules. So next slide, please. All lines are muted during the program. There is a Q&A box at about the middle of your Zoom screen. So please use that to ask questions, and we will try to get to as many of those questions as possible. Next slide. The webinar will be recorded and available on YouTube after this session. And this session is brought to you by a partnership between the California Immunization Coalition and the American Academy of Pediatrics, California. So I am Pia Pannaraj from UC San Diego, and my co-moderator is Eric Ball from Children's Orange County. And we will be moderating today's session, and I'll throw it to Eric to introduce our wonderful speakers today.
Thanks, Pia. We have a great session today with three amazing speakers. First is our returning champion, Rob Schechter, who's been with us many times. So Dr. Schechter is the medical officer with the California Department of Public Health Immunization Branch, and he does several things there, including running their immunization program, implementation management, vaccine safety, post-marketing surveillance, vaccine communications, health information technology, and development. So he manages CDPH's immunization program, which supports the nation's largest vaccine for children's program, which provides over 10 million vaccines to over 10 million eligible children, and also CDPH's annual supply of over 500,000 flu vaccines. He's also a pediatrician and a member of the American Academy of Pediatrics. We're also honored to have with us Dr. Jennifer Thompson, who's an associate professor and fellowship director in the Division of Maternal Fetal Medicine at Vanderbilt University Medical Center. Her clinical and research interests focus on infectious diseases in pregnancy and maternal heart disease. She's actively involved with the Infectious Disease Society for obstetricians and gynecologists, and where she serves on their council and as their membership committee co-chair. She's also a member of ACOG's Clinical Consensus Committee on Obstetrics and serves as ACOG's liaison to the Committee on Infectious Diseases at the AAP, which Dr. Pannaraj also serves on. And we are also honored to be joined by Dr. Jeff Goad. Jeff is a tenured professor of pharmacy practice and associate dean of academic affairs at Chapman University School of Pharmacy here in Orange County. And he is very involved nationally as the president-elect for the National Foundation on Infectious Diseases, the first pharmacist to serve in that role. And he was also the first pharmacist president of our organization, the California Immunization Coalition. So we have many skilled speakers with us today, and the format today is we are going to have Dr. Schechter lead us off talking about the landscape of RSV in California right now, as well as the state of immunization practices, and then we'll move to a Q&A session with all three speakers. So with that, I will throw this over to Dr. Schechter, and thank you all for joining us.
Thank you, Dr. Ball. Good afternoon, everyone. I hope you're doing well. This first slide, demonstrates RSV activity over several seasons, with the line with the red dots reflecting what's been going on in California over the last months. As in the last couple of years of the pandemic, RSV seasonality has been a little bit off, a bit earlier than usual, and we're seeing that again this fall. And rates from laboratory surveillance that CDPH oversees, data flowing in from different labs around the state, the rate of positivity of specimens for RSV has been increasing to levels which are comparable to some pre-pandemic seasons and getting close to peak levels for other pandemic seasons as well. So as you may be seeing in your clinics and hospital beds over the last weeks, RSV activity is increasing, and this is concerning in terms of a limited window, limited opportunity to prevent severe RSV disease in young children. Next slide, please. So this season started out with the optimism of having some new tools in the toolkit to prevent those hospitalizations and deaths from RSV in infants and high-risk toddlers, including the main topic for today, which is authorization and recommendation for one of the adult RSV vaccines for use late in pregnancy at 32 to 36 weeks gestational age. And then the availability of a long-acting monoclonal antibody, Nirsevimab, to be given either in the birth hospital or in outpatient visits to all infants younger than 8 months and to older infants and toddlers at high risk going into their second season. This was in addition to the tools already available. Before Nirsevimab has been Palivizumab, a monthly monoclonal antibody product for infants and toddlers, and then non-specific but powerful tools to prevent RSV and other respiratory infections in young infants, including human milk, including breastfeeding, to reduce either the incidence or severity of RSV and other infections, and then all the measures which have worked so well during the pandemic in reducing risk of not only COVID but also in other respiratory viral infections. Next slide, please. So that was the landscape going into late October when CDC issued this announcement of limited availability of Nirsevimab, the manufacturer's production for the season being far below the size of the eligible cohort of infant and children. And so for the last 6 weeks or so, been reacting to limited ability to order the 100 milligram formulation for older infants and toddlers, or the 50 milligram for those infants under 5 kilograms, with somewhat more of the 50 milligram formulation in circulation or available for order. Next slide, please. This slide summarizes the supplies, the inventory of Nirsevimab in California for this season. We at CDPH, we don't have access to the information from the manufacturer on how many doses have been ordered or remaining available for order on the private market. There has been the general announcement that the 100 milligram formulation is no longer available for order. And talking to public health programs around the country, it's the scarcity of the 50 milligrams appears to differ, but there's not a lot of those 50 milligram doses. We don't know exactly how many. On the vaccine for children's, this is the federally purchased product for children who are eligible for Medi-Cal, the Medicaid program in California, for Native Alaskan, American Indian children, or for uninsured children. You see the numbers in front of you of what we're expecting to receive for the whole season of the 50 milligram and the 100 milligram doses, about 38,000 50 milligram, about 100 milligram, about 20,000 of the 100 milligram formulation. And that's for a vaccine for children provider site population from small to very, very large, about 3,000 provider sites. So small portions overall. About half of those doses have been ordered by VFC providers, but there are some still available for order now if you happen to be a VFC provider. And the rest of these are projected to arrive during the duration of December. Next slide, please. So given this shortage in the supply of Nirsevimab, these limited doses, what measures can be taken? So if you're a prenatal care provider in an obstetric or a family physician setting, over the next months, you can administer directly in your clinic, or as an alternative, provide easily accessible referrals, guaranteed referrals to the prenatal RSV vaccination late in pregnancy. And then RSV vaccine joining a number of other vaccines, which can also protect the young infants against severe respiratory disease, prenatal influenza vaccine, COVID-19 vaccine, and the Tdap vaccine to prevent pertussis in early after birth. If you're providing care for infants in your setting, and if you're a VFC provider, I encourage you to promptly order those remaining limited doses. Again, from that disease curve, that test positivity curve on the first slide, the window is limited and closing over the next weeks to months. So really are hoping that all of those limited doses can be used to keep infants out of the hospital or worse. So to promptly order those limited doses available through VFC on the private market, and to promptly administer what little inventory you might have to protect those in need. And I appreciate that you're making tough clinical choices about how to divide up those supplies, but now is the time to call those patients in or to get those doses out. Next slide, please. And then regardless of your provider setting, there are these non-specific measures that can help to reduce the transmission of RSV and other pathogens to infants or the severity of those diseases, including breastfeeding, hand washing, cough and respiratory etiquette, and distancing and limiting exposures for the young infants. Next slide, please. You may have relating this reference is just to show a literature review, a systematic review of the data around breastfeeding as a measure to prevent severe RSV disease in young infants and toddlers. So as the dust clears over the next weeks, and we've done what we can to protect infants against RSV, the question about what can we do ahead and what problems to address going into next fall, late summer and fall 24-25. Some of those barriers to overcome include the production, adequate production for the need by the manufacturer. Another important issue, I think, for many providers is knowing that they'll be reimbursed in a timely fashion for these expensive vaccines and monoclonals. And one barrier to that has been under the Affordable Care Act, payers have up to 12 months to add on reimbursement for new products recommended by the Federal ACIP Advisory Committee on Immunization Practices. So with the introduction of the products this year, shortly before the season, clashing against this longer window that payers have to initiate reimbursement. Access points, you can have the product, but if it's not out in the field in the community, if it's difficult for pregnant persons or infants to access, this is a key issue, and we are hoping that by next fall that all birth hospitals serving Medi-Cal and other VFC eligible patients will accept an invitation to join the VFC program, and encourage you, if you're interested in that, to work with your local birth hospitals on that point of access. And there may be additional major and minor barriers as well to this difficult task of using these new tools to their full potential to keep infants out of the hospital and keep them alive and healthy. So with that, I will stop and pass it back to Dr. Ball and Dr. Pannaraj, and thank you for your attention.
Perfect. Thank you so much, Dr. Schechter, for this update of what's going on right now. You know, despite these hiccups, we've been so excited to have new prevention strategies for RSV. The RSV vaccine is the newest vaccine available for pregnant persons to help protect vulnerable babies, in addition to flu, COVID, and Tdap, as you mentioned. So I'm going to ask Dr. Thompson, can you please give us a brief introduction to the maternal RSV vaccine? Why do we need it, and how well does it work?
Yeah, absolutely. I think all of us know someone who has been affected with RSV and how devastating that disease can be for them and for their family. As we know, RSV is a potentially serious and even deadly disease for young children and infants, and a major cause of hospitalization among infants. And infants younger than 6 months experience the most severe morbidity and mortality. So this vaccine was developed as a way to help give baby protection immediately after birth and help to reduce those risks. In terms of how well it works, the initial study that was done, the Matisse trial, looked at a gestational age of administration between 24 and 36 weeks. So when we look at the whole study population, the efficacy in the reduction of risk of severe lower respiratory tract infection in infants was 81.8% in the first 90 days after delivery and 69.4% within 180 days. However, when we look at that population that's approved for the vaccine, the 32 to 36 week administration, we saw a reduction in lower respiratory tract infection by 34.7%, but among that severe lower respiratory tract infection, the efficacy was 91.1% within 90 days, and it went to 76.5% for that severe lower respiratory tract infection reduction at 180 days. So definitely showing benefit for that population.
Dr. Thompson, can you talk a little bit about why the recommendation was made at 32 to 36 weeks rather than the initial study, which started at 24?
Absolutely. The trial showed a signal for a concern about possible increased risk of preterm birth amongst candidates who received the vaccine versus placebo. It was about 5.7% in the vaccine group and 4.7% in the placebo group. It's unclear why there was that difference between the two groups. And as we know, preterm birth is very multifactorial. When we look at that number a little bit more closely, though, it appeared that that increase was seen majority in low and middle income countries, as well as countries that were in the Southern Hemisphere and possibly during their COVID season. And so we think some of that may all play into this. When we look at the US population specifically, and in that range of when the 32 to 36 week was administered, we see that that preterm birth rate is similar between the two groups, which is what led to this 32 to 36 week decision by the FDA because of this theoretical risk of possible preterm birth.
Are there, in addition to this concern, are there other side effects that, we should counsel pregnant parents about?
We haven't seen as much in looking in the study to see if there were other signals. There were similar rates of preeclampsia seen between the two groups, similar rates of low for gestational age birth weight. And so I think the biggest thing that we have been from ACOG and from our guidance to talk to our patients about does have to do with just this signal for preterm birth.
I have a question for Dr. Thompson and also for Dr. Goad. So we as pediatricians have been used to giving a lot of vaccines. That's a big part of our job. And I think over the past 10 years, that role has really shifted for adults. And our obstetric colleagues and our pharmacists are now taking on the lion's share of giving a lot of vaccines to adults. So Dr. Thompson, among others, you guys are giving to all pregnant people flu vaccines and COVID vaccines and RSV vaccines and Tdap vaccines. And for Dr. Goad, like pretty much most adults now, including myself, are going to pharmacies for all of our vaccines. So multi-part question. So for Dr. Thompson, how is that affecting your training, or are vaccines becoming more ingrained in what you guys do? And then Dr. Goad, how about for you and your colleagues, in particular for pregnant people? Because I have had some feedback from some patients that some pharmacies were not vaccinating pregnant people because they were pregnant.
Yeah, from the standpoint of vaccines and pregnancy for pregnant people, we now have a number of vaccines that we recommend. And so vaccine counseling and vaccine administration is something that is becoming more ingrained as part of our training through residency and fellowship. I think when we look at things that improve vaccine adherence through pregnancy, we know that being able to get vaccines in clinic the same day as they're discussed really helps to increase the acceptance rate among patients. And so trying to do that, but obviously, as you said, that's not available for everyone. And then the pharmacies do become our location to send our pregnant patients to. So we do a lot of vaccine education and counseling. I think as you all had seen too through the COVID pandemic, we do have, I feel, a lot more vaccine hesitancy. So a lot more education and counseling goes into these discussions. And for my practice, I bring it up is usually at like the first visit that I see patients and kind of lay out, these are the vaccines, these are why we recommend them, and these are the timing that you'll be getting them, in order to continue that conversation throughout their pregnancy, especially if they're someone who isn't as open to getting their vaccines.
Yeah, and I think, from the pharmacy setting, as you mentioned before, pharmacists were really involved in adult vaccinations from the very beginning, which was really need-based. So, you have to look 20 years or so back to see when, adult vaccination rates were declining. We always complain about declining adult vaccination rates, but they were pretty low back in the 90s and early 2000s. And so there was a great need to bring in another vaccination source, another place for patients to go to get vaccines. And over the years, pharmacy has really kind of participated in need-based care. So COVID pandemic, for example, brought on another need-based in different age groups, especially in pediatric age groups across the country. So a lot of what pharmacy does is need-based. What's really helped kind of expand beyond flu shots, which is where pharmacy really started and still continues today to give flu shots, but really helped expand was really expansion of scope of practice. So throughout the United States now, you can get an adult vaccination in every state. It wasn't always that way. There was really a patchwork of solutions across the country to get vaccinations for adults, and there still continues to be a patchwork for younger children to get vaccines. So the other thing, of course, that's helped is insurance coverage. Patients used to have to pay out of pocket at pharmacies, and now insurance now covers it under either vaccine benefits or under the medication benefit, the health benefits. So there's various ways in which patients are able to get their vaccines covered at the pharmacy. And of course, offering more vaccines, right? So if they only offer flu, then you don't think to go there for a Tdap or an RSV or others. But over the years, pharmacy has really expanded their offerings of vaccines so that patients can now rely on the pharmacy as a source of many different vaccines. And lastly, not that this is a good sign, but this is what's happening in the market. It's what pharmacy is seeing, as well as others, is medical offices, specialists, for example, not carrying vaccines as often as they used to. I think, as was alluded to, some of that shifting Dr. Thompson mentioned to pharmacy occurs not because they're trying to divert patients that way, just because offices have stopped carrying vaccines. So for many reasons, a lot of it has shifted to pharmacy. But to your last point about the pregnancy side, there really are no restrictions I know of nationally against pharmacists vaccinating pregnant patients. Most of any of the restrictions across the United States are either vaccine specific or age specific, but I've never seen a pregnancy specific contraindication. So if you're seeing those, that's imposed by the company or the independent pharmacy that is the source of the vaccines, whether it's a chain or independent.
Yeah, I had a follow-up question on that because one of the issues that we've been seeing, I've actually had this happen a few times now, is a pregnant person goes to their obstetrician, talks about the RSV vaccine. For whatever reason, they don't have the vaccine or they're not vaccinating. So they give a prescription to take to the pharmacy, and then they had a hard time finding a pharmacy that was willing to do it. And so there to go. So my question is, so that's good that there's no laws against that, but can you talk briefly about the actually the laws that there are in place about ages and, for my patients, for example, and what you recommend we do for those families. Because unfortunately, that woman ended up delivering a baby who was unprotected. And then now we have our whole issue as pediatricians trying to get Nirsevimab, which we haven't been able to do. So this person was kind of blocked at 3 different levels of our healthcare system, which is quite disappointing.
Yeah, and that's disappointing for me to hear as well, is that a patient was turned away. Because, you have to realize pharmacy has been vaccinating for influenza in pregnancy, and then Tdap in pregnancy, and then COVID in pregnancy. RSV is really just the last in the line of vaccines that pharmacists would have been giving to pregnant patients. So it's really disheartening to hear that, patients are being turned away just for that reason, versus they don't have the vaccine in stock. So I think one of the things we can do is, one is make sure that patients are asking for it at the pharmacy, and to make sure that, from our side, we message pharmacists all the time to make sure they understand they can vaccinate pregnant patients. It's built into the training programs, it's all throughout, but some of it is a comfort level. From a corporate level, I've actually not heard those anymore. It used to be early on with flu and then into Tdap. There was some of the corporations have maybe more attorneys than they do providers, but those have long gone away. And most of the corporations now, the large chains, have no restrictions on vaccinating pregnant women.
Some of the information, just to that point, that we had been hearing through our organizations had to do with pharmacies not being certain which vaccine they had, if they had GSK or if they had Pfizer. And so if they weren't certain which of the 2 vaccines they had, or if they didn't have the Pfizer vaccine, which is the one that is approved in pregnancy, then patients were being turned away. And so I know that CDC and ACOG had been working a lot with the pharmacy organizations to ensure that with the order that patients are getting the correct vaccine and not getting a vaccine that's not approved in pregnancy.
Yeah, no, absolutely. I just checked with a few of our chains within California, and of course, what pharmacy tends to like to do is to stock, which I'm sure medical practices do as well, stock the vaccine with the greatest number of indications, right? So that you can cover a greater swath of your patients. So the Pfizer vaccine for that.
Great, thank you. I'm going to jump back just a little bit to talk a little bit more about the RSV vaccine itself versus Nirsevimab. So when Nirsevimab is the monoclonal antibody used to given to infants, as you all know. So when the vaccine was first recommended, there was a role for shared decision making with the family to decide, okay, do we give the maternal vaccine or do we wait and a baby's born and then give Nirsevimab? So my question is, what are your thoughts about this shared decision making? And then what about now during this shortage? What's the role of shared decision making now?
Yeah, I think shared decision making is really important in talking with families about these kind of options. I think this season it's a lot more challenging given the shortage of Nirsevimab and really trying to ensure that those infants are protected and advocating for maternal vaccine. In terms of, I think when you have patients that are hesitant about maternal vaccine, really exploring those reasons, especially in this setting of shortage, and trying to decide or figure out or know if your hospital is going to be able to provide infant monoclonal antibody. And I think it's really hard in the climate that we're in right now to know what's going to be available for the infant and if your infant would qualify. And so I think really advocating for maternal vaccine this season is going to be really important. And in that shared decision-making discussion, we just talk about kind of what are the benefits to maternal vaccine versus what are the benefits to infant monoclonal antibody. And for some people, the fact that it would reduce the number of vaccines for their infant, and that the infant, as long as it's vaccinated, as long as mom got the vaccine more than 14 days before delivery, should have those antibodies for protection and have that immediate protection after delivery, I think is really important. And for other people, monoclonal antibody, they prefer that those antibodies might last longer and that it's more of an active development versus passive transfer. But I do still think there's a role for shared decision making, but I really feel in this climate this year, when we have such a shortage, that maternal vaccine really needs to be advocated for.
If I can take a little bit of a, not necessarily a counter view, but a different view of shared clinical decision making from the pharmacy level, it is very difficult to implement, right? And in a climate where there are confusing recommendations, you only have to look at pneumococcal or meningococcal to get very confused quickly. Simplicity is usually the best way to ensure that we're able to vaccinate a population. So understanding that shared clinical decision making is really utilization control, right? Where in patients you're not sure of the benefit in those without high risk, you then run the risk of patients not getting vaccinated. So for example, in a pharmacy, this means that the patient really has to self-identify because they don't really have access to the electronic health record to get all of the high risk indications that might be good prompts for a shared clinical decision making conversation with the patient. So we're relying on the patient to come in and ask the pharmacist to have that conversation. So shared clinical decision making does decrease opportunities, at least at the pharmacy level, to get patients vaccinated.
I have a logistics question that I'll throw out to the three of you. Three people already asked this in the Q&A box. So for us, for Nirsevimab, not only is it in short supply, but we are having a hard time getting insurance companies to pay for it. And it's very hit or miss who's going to pay for it. So I'll read a question from the Q&A box. So as an obstetrician, I counsel my patients, and almost all are willing to get the vaccines I recommend. However, we are currently having patients sign a form that says they would be willing to pay $400 for the RSV vaccine if their insurance does not cover it. This is the biggest barrier to getting my patients to get the RSV vaccine. So I was unaware of this. Has this been an issue with the adult and maternal RSV vaccines as well?
Yes, that's what I've heard from others as well, that because, as was mentioned in the presentation, the rollout was so close to RSV season that insurance companies have that lag time to decide coverage. And so, yes, cost has definitely been a barrier as well for maternal vaccine.
And that's been the same experience in pharmacy as well. It's getting better, but certainly there are holes in coverage.
How does that work in a pharmacy setting? Do you have, because we have the same form that we give to our patients, but I've gotten lots of vaccines in pharmacies, but I've never had to sign something that says I'd pay cash. Does it work differently?
Yeah, so it depends on how the insurance is set up. Sometimes the vaccine benefit is through the pharmacy benefit, which means it gets adjudicated just like a prescription drug. Sometimes it might be through the medical side, in which case there has to be either another form, or if the pharmacy is connected, for example, to be able to bill non-prescription type drugs, then they can run it through that system. But most are shifting over to the prescription drug benefit side to allow for an easier transaction in the pharmacy, which is why you probably haven't had to do anything. Just walk in there, get your shot, and they bill it on the back end.
Dr. Schechter, can you talk briefly about the legality of this? These are vaccines that are recommended by ACIP, and I thought insurance companies were required to cover those.
I guess one question I'd ask is, are the settings in network for the payer? When is the payer started covering reimbursement within the window permitted by federal law? As again, one of the provisions of the Affordable Care Act, they have up to 12 months to initiate that reimbursement within their system. And then secondly, that reimbursement would be limited to in-network sites. And either or both of those might be obstacles for some of the situations and the anecdotes and other situations we're hearing about.
So they have a year to not cover an immunization after it's approved?
Some have been prompter, but the law permits up to 12 months after the recommendation is published, I believe, not even after the vote. It's once there's a written recommendation in place.
Do you have any updates on which of the big insurance companies have been covering the RSV vaccine this year?
We don't have a comprehensive list either for Nirsevimab or prenatal for covering prenatal immunization. I think there have been some press releases by payers about it, indicating their coverage. I don't know to what extent those are all variations in their plans to, given the sort of different flavors or variations that even a single insurer can have for their plan.
Yeah. As you know, one of the CDC has tried to improve the speed at which the new immunization schedules come out to try to address this issue, so that the insurance companies cannot use that as an excuse that the vaccine or immunization is not available or is not on the immunization schedule, and therefore they're not yet required to give it. So the new vaccination schedule for 2024 has actually been published already just earlier this month. And with that, on the online version, anytime there's a new update, there is a addendum to the vaccination schedule. It's currently blank, but on that addendum will be the latest ACIP recommendations, so that there's no excuse to not provide the immunizations that are recommended.
It will be a lot. These will be ironed out by next year, but it leaves everybody in the lurch right now.
Right. So one question I have is, how can we, because if the pregnant parent received the RSV vaccine, then within 14 days of delivery, then the infant does not need to receive the monoclonal antibody. How is that communicated to the pediatrician or the provider of the infants? And how can we ensure that the immunization registry is also being used? That can be a question for all three of you, I think.
Yeah, I can take it from the pharmacy side, that immunization registry is sort of our primary communication tool in California. Other states have very different rules around who reports, how often, things like that. But within California, all of our providers now should be reporting to the immunization registry and being able to access the immunization registry. So when you have problems with interoperability among systems, we do have at least one system where everyone can, put their immunizations in and then go in and check. In a perfect world, we'd be able to connect with the EHR from a different medical group, and they'd be able to query the pharmacy's database as well. But until that happens, we have an intermediary source, which is the registry. So it is an important communication tool.
I'll say that at our institution, a lot of work has gone into the EHR to make sure that there's communication amongst our various clinics. I am not certain how the pharmacy piece is working for us here in Tennessee, because we don't have a centralized immunization record for adults. And so I think that makes it at times a little bit more challenging.
I'll just add that the California Immunization Registry has the doses of either Nirsevimab or adult vaccine can be entered. That capability has been programmed in going into the availability of the products, and for the infant provider is able to look up the mom's record to see the pregnant parent's record to see whether or not there's an indication of prenatal immunization or receipt in the birth facility of Nirsevimab. It doesn't guarantee that the record has been entered, but the capacity is there.
Dr. Schechter, two questions from our Q&A about our California VFC program. So one was if they are covering and providing the RSV vaccine for pregnant people, and two is can pharmacies participate in the VFC program, and if not, why not?
So I believe that the RSV vaccines are a covered benefit under Medi-Cal for adults 19 years and older. in which the purchase happens by the provider, and then the Nirsevimab and the vaccine have been added into the Vaccine for Children's program. Nirsevimab is available for order now. The RSV vaccine is just if you have adolescent patients, pregnant patients, it's just ready to order now, the vaccine for those. Nirsevimab you can order to now. The vaccine for a pregnant teen should shortly be available for order. And then there are a limited number of pharmacies that are currently in a pilot project as VFC providers, and expecting that to expand more over the next months and years. But right now, pharmacy access for VFC vaccines is fairly limited in California, with the exception that I'll go off topic here, that our state Medicaid program, Medi-Cal, has announced that under federal guidelines now, all pharmacies can provide and get reimbursed from the federal government for COVID-19 vaccine. So there's this important exception, and I'll stop there. But so you could get your COVID vaccine as a child or adolescent in a pharmacy, but if you're VFC eligible, there's only a few pharmacies that are currently providing it.
Dr. Goad, do you have anything to add about VFC and pharmacies?
Yeah, I think it's an encouraging sign. One of the challenges in the past is to get pharmacies, one, interested in providing VFC vaccine, but then also for the state to develop capacity and ability to reach out and work with different providers. Obviously, they have an expertise around working with pediatricians, so developing that expertise around working with pharmacies has been coming along. So I think we'll get there. I think pharmacists do want to participate, because not being able to bill for vaccines administered to children in the Medi-Cal program is a challenge if you go out to do, for example, school-based vaccinations or other on-site, and you have to turn away those who are covered by Medi-Cal versus those who are covered by commercial insurance. So it is a hole that we'd like to fill.
So we have on the call, we have OB providers, pediatricians, we have frontline folks who are giving the vaccines, nurses. How can we as a group help to advocate for these vaccines, for the use of pharmacies, for the OBs to give vaccines now that we have these vaccines available?
I think from a perspective of just continuing to have more education, things like this, talking about the vaccines and educating our patients, and from a pediatric point of view, you educate your parents all the time when they come in for pediatric visits, and just talking about that to prepare for if there's a future pregnancy. And I think the more we talk about and educate our patients, I'm hopeful that there'll be less hesitancy and more uptake of all the vaccines that are recommended.
And I think from a pharmacy perspective, encouraging, again, because of the shared clinical decision-making model, it's encouraging patients to be empowered and aware of the needs. So, for example, maximizing social media, especially younger adults who maybe that is their primary, they're not watching TV commercials, which there are plenty of those coming out, but to really maximize the social media opportunities to get people educated. I think we're missing some there, and we need to maximize those.
Is there anything special that you think we need for the OBs? Because I know that there is still some resistance from obstetricians about giving the vaccines, just because it's hard to incorporate it into the practice, or hard to have all the vaccines available. Is there anything that additional that you think we should try to do to help? That question's probably for Dr. Thompson.
Yeah, I'm thinking about how best to advocate in that arena, I think the good news about the RSV vaccine is it doesn't require special storage like the COVID vaccine did. So it makes it a little bit easier for people to have in their practice. But I think to have vaccines in your practice, you have to have a good uptake among your patients so that you're not out that additional cost. And so I think just trying to figure out how best to do that. And I'm sorry that I don't have a good answer to how to advocate for that amongst our practices.
Thank
and
you.
I think just a quick, for pharmacy, I think, again, because of the model that's there where you can't reach out to a general population, which is generally how pharmacy notifies patients or identifies them, is pharmacy does have the advantage that somewhere around the U.S. size of the U.S. population walks through a door where there's a pharmacy every week. So there's a lot of visibility. So pharmacy being able to do what's called in-store advertising actually works very well. When people are walking around and shopping or doing whatever they're doing and see that they're offering the vaccine, sometimes it's convenient, it's there, and they'll get it done. So our mantra is always whatever it takes, right, to get people in there aware and vaccinated. Pharmacy needs to prioritize vaccines during certain parts of the year. Certainly can't have a poster with every vaccine on it. It'll just overwhelm people. But being able to pace some of their campaigns is important.
I agree. That has been effective. I've had many patients who they defer their flu or COVID vaccines in my office to get in the pharmacy for their 10% off of their groceries or what have you. So every little bit helps.
Yeah, whatever it takes.
Hey, Dr. Thompson, I want to go way back to the beginning and just a few more logistics questions. So when seasonally, what months are we giving the RSV vaccine to pregnant people? And is there, someone had mentioned in the Q&A, is there any wiggle room to the 32 to 36 weeks? Or if the baby delivers 10 days after the shot, like what happens? Could you address those logistical issues?
Yeah, so the seasonality, our recommendations are September to January through January for RSV season. So similarly to the flu, except we give the flu a little bit longer. So it looks like a narrower season for us with RSV. And then in terms of the gestational age, the recommendation and what was approved was the 32 to 36 weeks. So through 36 and 6. The reason that date was picked was to ensure the greater than 14 days from vaccine to delivery to get those antibodies. If you have a patient who is known going to be delivering less than 14 days from when they would get the vaccine, it wouldn't be recommended to give them the vaccine because the antibodies wouldn't have formed yet and they would still be a candidate for Nirsevimab. I have had questions about, well, what if they're 37 weeks? And the approval was through 36, so that I don't know if insurance would pay outside that range, as we're already kind of uncertain with some of the costs. So I would stick with that 36 to 32, but it's ideally so that you can get those 14 days from vaccine to delivery, at least 14 days.
I think it's especially difficult now with the shortage of Nirsevimab, as a really difficult decision.
And I think that was those first questions about the wiggle room came out when we just got the vaccine here. And so some people had already missed the window. And so the question was, are we able to or not? But I think it's really hard, but I think for, reimbursement and whatnot, we have to stick with that 32 to 36.
So here in California, we are seeing a lot of RSV already, and it's hard to know exactly when the season will peak and when it will come down. So if the RSV season extends past, January, will we still be giving the vaccine?
I would say yes. I would say yes.
Okay. So there are some questions that I think you might have actually answered in the chat, Dr. Schechter, about what is the forecast for Nirsevimab in the upcoming months, at least for the rest of this season?
So we've been told by manufacturer and CDC that to expect to receive the remainder of our allocation for the season by the end of December. And so that's about, the numbers are not going to be precise, but maybe 15 to 20,000 of the 50 milligram doses that would be remaining that haven't been ordered yet from that. And that's a much smaller, some thousands of doses of the 100 milligram product that are still available for order, fewer than 10,000. So I think with that disease curve and that supply chain, again, time is of the essence. And if you have a way of getting your high-risk kids back in, great. And if that's challenging, thinking about trying to avoid missed opportunities, limited time left to protect those babies.
Dr. Schechter, with the shortage of Nirsevimab, are you permitted to give 2 50 milligram doses to a larger child to equal 100, or do we have to stick with the 100 milligram doses?
The national recommendation is to preserve those 50 milligram doses for the kids under 5 kilos, rather than to double up or quadruple up for the older infants and toddlers. Again, very difficult decisions in a clinical setting between your children in need.
Yeah. I've also been asked the reverse of that question. Can we split a 100 milligram dose to give to 2 babies?
Yeah, I think typically the recommendation is to try not to do that for aseptic change, for keeping those products sterile and avoiding unintended infection risks. And so typically the recommendation is stick with the indicated weights and ages.
I know that the guidance has changed as to which kids we're giving Nirsevimab to this year, but Dr. Schechter, like in my office, we have like 20 doses left for probably the remainder of this season. So how do you think pediatricians should prioritize those limited doses?
Very, very sympathetic, very, very difficult decisions. I think I would look at the clock, though. I would look at that curve, and you know, in a perfect world, you could figure out which children were at the very highest risk, bring them in, and give those doses out. And I think balancing that with the limited number of weeks to intervene to be able to protect them this season, it would be my decision. So in some cases, giving to other eligible children, even if they're not at the highest risk, because people can anything now, may make sense in the practice setting.
As we near the end of the hour, I wanted to ask a question to all 3 of you in thinking about the future. So how do we utilize this current RSV immunization supply issues to help us better prepare for the future, to prepare, pediatricians, OBs, all those pharmacies, all vaccine providers in the future? And how do we strengthen patient trust?
Well, I guess I'll go first.
Tough question, but please go ahead.
That's a loaded question. That's
yes.
a lot in there. Yeah, I think we probably all agree that the rollout this season was not optimal in terms of RSV vaccines now they came out. So I think going forward gives us time to plan, to get the messaging right, to get the timing right for the messaging, and hopefully RSV seasonality begins to get into a more predictable pattern that allow for the campaigns and the public awareness and provider awareness campaigns to happen on schedule, so that we can get vaccine out to vaccine providers and then the information out to patients so they know to come in for it or to be ready to receive those vaccines. So I think we have time to plan. The question is, will we use the time wisely and plan accordingly for next season? This season, we're doing the best we can.
I would definitely agree with that. I think this season, everything was just so compressed, and the rollout just didn't happen as we had all hoped. I think we also enjoyed the rollout from COVID vaccine once that got approved. And unfortunately, this rollout, I think, is more typical of other vaccines pre-COVID, but just continuing to learn from this. And as was said, plan for next season. I think it gives us time to talk with patients and in our institutions to figure out what our goals are going to be for next year.
Any thoughts from you, Dr. Schechter?
That I would just add that some of these are a number of upstream factors, but some of these are will be ongoing policy challenges. Is there any ability to modify federal policy on reimbursement and timeliness of reimbursement? Are there what have the manufacturers learned about supply chain or projections? And for some of those larger external issues outside of individual practice control, in which dialogue and preparations can be made for next season.
I appreciate those closing comments. I think one of the only good things to come out of our COVID pandemic is that I think we're kind of getting more out of our silos. And I really appreciate the fact that we're able to be joined by colleagues from various disciplines to kind of work together to protect our families and our children. And through California Immunization Coalition, we've worked extensively with our family practice colleagues, our OBGYN colleagues, our pharmacy colleagues, our public health colleagues. And I think we're viewing public health, we're viewing health of children now, not just in our own pediatric world, but outside. And so we really appreciate everyone joining us today. We have been doing these since the beginning of the pandemic. I think this is like the 15th or 16th of these webinars that we have done. We initially did them on COVID, but now we're doing them on all kind of hot topics in immunizations and infectious disease. So you guys will receive an evaluation after our webinar, and please fill it out and talk about other topics that you would like for us to address in the future. Also, we've done some of these at night and some of these at noon, and let us know what works better for you. We definitely have great participation for these noon conferences. So thank you for joining us. And with that, stay tuned. And again, thanks to our staff at the California Immunization Coalition for putting this together. And you can find all of our talks on our YouTube channel, as well as on our website at immunizeca.org. And with that, thank you to Dr. Schechter, Dr. Goad, Dr. Thompson, and Dr. Pannaraj for joining us. And we look forward to seeing you on the next one. Thanks so much.
Thank you, everyone.